Good evening, everyone. It's my pleasure to welcome you to this virtual scientific meeting developed by the American Neurogastroenterology and Motility Society, focusing on basic concepts in neurogastroenterology. My name is Beverly Greenwood van Meerveld, and I am the immediate past president of the ANMS and current director of the ANMS Institute. The goals of these virtual symposia are twofold: to provide you with the latest exciting information on scientific topics related to our field of neurogastroenterology motility, and allow you to connect virtually with leaders in our field of neurogastroenterology motility. And the title of today's ANMS Symposia is Brain-Gut Behavior Therapy for Treating GI Disorders. And before we start, I'd like to personally thank each of our three speakers today for taking time out of their busy schedules to join us. I would also like to thank all the members of the ANMS Virtual Meetings Planning Committee who have been working with me to develop this program tonight, as well as the 2022 virtual sessions for basic concepts in neurogastroenterology motility. Please visit the ANMS website for further details on all upcoming ANMS virtual events. I'd also like to bring your attention to the ANMS Basic Science Mini Sabbatical Program in neurogastroenterology motility. And this program is specifically designed to help investigators obtain new research skills that will promote their careers as independent investigators in our field. Now, the application deadline has been extended until January the 14th, so please visit the ANMS website for further details. So it's now my great pleasure to introduce today's moderator, Dr. Miranda van Tilburg, who is Professor of Medicine and Vice Chair of Research at Marshall University Jones C. Edwards School of Medicine. She's also an adjunct professor of medicine at the University of North Carolina and affiliate professor of social work at the University of Washington. Dr. van Tilburg has been a previous ANMS council member and remains actively involved in the ANMS. Thank you, Dr. van Tilburg, for moderating today's event.
Thank you for that introduction, Dr. Greenwood van Meerveld. I am really excited about today's session. I think it's going to be wonderful. And I have a great honor to introduce some really excellent speakers to you. So the first speaker for tonight is one of the major ones in our field, Dr. Laurie Keefer. Dr. Laurie Keefer is a GI health psychologist and professor of medicine and psychiatry at the Icahn School of Medicine, Mount Sinai in New York City. She has more than 20 years of experience in the development and implementation of behavioral therapies for chronic digestive disorders, including IBS, GERD, and IBD. Dr. Keefer is the founder and co-chair of the Rome Foundation's GastroPsych group, very active group. Please do look them up and sign up. And she also serves on the board of directors of the Rome Foundation. Dr. Keefer has more than 200 peer-reviewed publications and recently co-edited the Handbook of Psychogastroenterology for Mental Health Professionals. I could not be more excited to have her here. Dr. Keefer, we're looking forward to your talk.
Thank you, and thank you so much for inviting me. I'm really excited to talk about what's new in cognitive behavior therapy, along with my co-speakers. So, as you know, ANMS is very near and dear to my heart. So I'm very excited to be able to do this virtual grand rounds today. So I'm going to talk a little bit about cognitive behavior therapy. And because many of you have probably seen me talk about cognitive behavior therapy, I'm actually going to sort of do more of an update of what's new. What do we know? We know it's a very effective evidence-based intervention for IBS, but what else? What can we? What is new and cutting edge, and what are the future directions here? So we'll talk about that, and we'll also talk about one of the other exciting things about cognitive behavior therapy, in that it is no longer just about treating irritable bowel syndrome. It's actually also been translated and adapted for a variety of other disorders of gut-brain interaction, including some motility disorders as well. And I would urge you to also check out the recently published Rome Working Team report on brain-gut behavior therapies for disorders of gut-brain interaction. We're going to hear from my colleague, Dr. Kinsinger, in a little bit as well about another brain gut behavior therapy, gut-directed hypnotherapy. So today I'm just going to talk about the basis of CBT GI. So cognitive behavior therapy, for those of you who need a reminder or refresher, is a theoretical orientation. It is not just a set of techniques, which is really important, especially when you start to look at the adaptation of cognitive behavior therapy across the spectrum of DGBIs. So basically what we mean by a theoretical orientation is that the belief that patients' thoughts, feelings, and behaviors are all connected, and changes in any one of those things can lead to changes in the other. So thoughts about your symptoms could change your behaviors about your symptoms, or your feelings about your symptoms. Changes in your behavior could affect changes in your thoughts or feelings. And so the CBT therapist really sees patients as having skills deficits that have developed in the context of their GI symptoms that may have made sense at the point of diagnosis, but have become problematic and disabling. And so the goal of the CBT approach in GI is that you're really retraining the patient's brain to think differently in response to their symptoms. And this is also another important component, is that cognitive behavior therapy can be highly personalized based on a collaborative relationship between the patient and their provider. And again, because it can be so personalized, it can really be applied to a full range of symptoms, even though the most evidence, of course, as you know, is in irritable bowel syndrome. So what are some of the techniques? I mentioned before, it's not just a set of techniques, but there are a lot of really good techniques that we can use with our patients. And so these are just a few of them. I'm going to talk particularly today about a technique that's growing traction called interoceptive exposure. But as you can see, several different behavioral techniques can be considered as part of that cognitive behavior therapy orientation. Just before I get into what's new, I just wanted to talk a little bit, remind everyone that, when we're prescribing cognitive behavior therapy to our IBS patients, or to any of our patients really, the goal is to treat their physical symptoms, to treat their GI symptoms and their GI specific quality of life. So these are not necessarily patients who are coming in and complaining of depression or anxiety. These are patients who are complaining of abdominal pain, of urgency, of diarrhea, of nausea, right? The goal of these therapies, what makes them brain gut behavior therapies, is that they have been adapted from mental health treatments that are well established and evidence-based. They have been adapted to directly address the way that patients think about and experience and behave in the context of their GI symptoms. So here are two of the largest randomized controlled trials that have been conducted to date, both with over 400 patients. And you can see that the primary endpoint, or one of the primary endpoints for all of these CBT trials, is the IBS symptom severity score. And you can see that the study on over to the left was conducted in the UK, and it was delivered via telephone and by web. And you can see substantial reductions over a year's time. Patients received treatment early on in the care, and then they followed them over time, showing that these are durable and that symptoms continue to improve over time because patients have learned how to process their information differently, how to process those sensory experiences from their GI tract. The same is true in the IBS-OS outcome study, which was a 4-session sort of minimal therapist contact CBT protocol for GI patients as well. Similar reductions in IBS symptoms over a year, again, supporting this concept of durability. So that's what we kind of know. And one of the more exciting aspects is now that we have the tools and techniques to really be able to quantify cognitive behavior therapy, manualize it, distribute it, train people in it, right, we can start to really look, confirm what we as psychologists have always suspected, but that is the mechanistic basis for it is actually truly the gut-brain microbiome axis. So this is a hot off the presses study that looked at 84 patients undergoing cognitive behavior therapy for IBS, according to the Lachner protocol. And they captured both brain imaging and microbiome data on these patients pre and post treatment. And one of the things that really kind of came out was that not only can you sort of see changes in brain structure, resting state structure as a result of learning new skills, learning new ways to process information, you can actually potentially predict which patients might be likely to respond to CBT for their IBS based on their baseline microbiome and their baseline brain imaging. Again, the more we can sort of show what treatments work for whom, the more exciting this research gets. So a couple of the new things, I just want to go through them. So first of all, the COVID pandemic has really highlighted the need for symptom management in disorders of gut-brain interaction. And also because we have access now to telehealth and to video, Dr. Kinsinger is going to talk a little bit about some of her work in that area. We were able to see the increase in these cognitive behavior therapies all around the world. And I wanted to just highlight this particular study that's out of Japan, because one of the things that is really interesting is that they took the CBT standard protocol, but they also built on the early work of Michelle Krask and the UCLA crowd on adding into cognitive behavior therapy something called interoceptive exposure. So interoceptive exposure is basically having a patient re-experience their GI symptoms. So they could tighten their belt, they could eat a meal, they could do something that would sort of trigger their symptoms. And instead of doing something that would make them try to avoid it, right? Take an Imodium, lie down, engage in pain behavior. We ask them to just sit with those feelings and to tolerate them and to let them ride away and run, kind of ride out over time. So this is really kind of an exciting area, and it has been shown to be able to, has been done in IBS treatment for a while now, but it's exciting to start to see that some of these exposure exercises that are really an important part of that brain-gut microbiome recovery can be delivered online. And the other component of that is, you may say, well, if CBT is so great, what is the point of adding interoceptive exposure? But one of the things that they have also been able to do with a variety of cost effectiveness analysis tools is out of Sweden, Brian Yeltsin's group was able to show that when you do add interoceptive exposure, even though it takes up a little more therapist time and maybe patients are a little less comfortable doing it, it's actually more cost effective over time. The return on investment, the reduction in symptoms and the reduction in ancillary symptoms, not just IBS symptoms, is actually worth adding that interoceptive exposure. So I would encourage those of you who are out there doing CBT work in DGBIs across the board. I mean, this has really been shown in IBS, but I would really kind of encourage you to think through whether that is something that would be additive to your practice. The other really exciting thing that is happening in the cognitive behavior therapy space is in the prescription of digital therapeutics, right? And so many of these, I think I had shown you the slide on the IBS study from the UK that used telephone and web delivery. That actually is they were able to take that study, the treatment that was offered in that study, and kind of distill it down or kind of create it into something that would be more interactive for patients And they were able to convince the Food and Drug Administration that it was a good enough standalone intervention that if a GI doctor thought that they could, that a patient would benefit from cognitive behavior therapy, they could actually just go ahead and prescribe that app to the patient. And I think this is really revolutionary. We'll have to see what, post-marketing data looks like and all of those things. But, the concept of, access to a GI psychologist is so limited, right? And access to somebody who really is able to deliver a protocol that has been tested and evidence-based and has been developed by experts and has brain imaging data and all that stuff that I just showed you. It's really exciting that, we're going to be able to start prescribing potentially for a subset of patients apps for cognitive behavior therapy. So this one is from Mahana. It is FDA cleared, but don't worry, there are many others that probably in the pipeline. Another one that has also based on a published empirically validated cognitive behavior therapy protocol for IBS is Zemedy. And so again, very exciting digital therapeutic. So in my last couple minutes, I'm just going to also talk about, not only are there a lot of advances moving the field forward in IBS, sort of our gastro-psych bread and butter, if you will, but there's actually also a lot of really exciting work done in other disorders of gut-brain interaction. So for example, there is a new published manual from Helen Murray at Mass General Harvard that provides cognitive behavior therapy for rumination syndrome. And what's exciting about this is that, many of you have seen me, I've done live demos of rumination syndrome for ANMS, with diaphragmatic breathing, but there is a subset of patients for whom that need an additional amount. And so this was a study that showed that when you added cognitive techniques to the diaphragmatic breathing, that you actually saw additional effects for patients that were really kind of refractory in their regurgitations and ruminations. So again, being able to adapt these concepts, personalize these concepts, expose patients to their discomfort, help them challenge the way that those that urge maybe to regurgitate or ruminate might occur, address thoughts around eating and behaviors, all of those things when applied to rumination syndrome, again, could be potentially a new area in which gastropsychs could intervene. And then similarly, this was another study looking at cognitive behavior therapy for supragastric belching, which we also know is a problem that many of us face and have to help patients deal with. And when you, I couldn't get through an ANMS slide deck without showing a normalization of manometry readings. This is a study with about 25 patients undergoing cognitive behavior therapy for supragastric belching, and you're seeing not only a really significant reduction over time in the number of belches, you're seeing normalization of their esophageal sphincter pressure, as well as there were some also changes in reflux. So, didn't get a chance to tell you everything about what's going on, but there's a lot of really exciting things going on in CBT for GI disorders. We're continuing to apply things. We're continuing to dismantle what works for whom. What is the story behind interoceptive exposure? What about context-based therapies? And we're going to hear from the third speaker tonight is going to sort of tell us why enriching a patient's context and environment may be another way to generate additional support for cognitive behavior therapy in disorders of gut-brain interaction. And then finally, the other exciting thing is really trying to digitize and scale when possible. And don't forget to join. We have a gastropsych group that we would love for you to participate in. You don't have to be a psychologist. You can be an advanced practitioner. You can be a physician, but we have lots of trainings, webinars, educational materials that would also hopefully keep you up to date. with our with the progress in our field. And I will stop there and let you hear from my other colleagues. Thank you very much.
Thank you for this very exciting talk, Dr. Keefer. I know there have already been a lot of questions, and I failed to tell you to please put all the questions in the Q&A. We will try to address questions after all talks have done today. So bear with me for a minute until all the speakers have had a chance to talk. And then if any question does not get answered today, because we're running out of time, they will be addressed by the speakers on Doc Matters later. And you will get information on how to access Doc Matters if you don't know that by now at the end of all the talks. So the next speaker I'm going to introduce to you is Dr. Sarah Kinsinger. She's a director of behavioral medicine for digestive health and associate professor of medicine at Loyola University Medical Center in Chicago. Her research and clinical interest focus on the use of brain-gut behavioral therapies to improve outcomes for patients with chronic digestive disorders. Very excited to hear what you're going to add today. Dr. Kinsinger, I'll leave it all up to you.
All right, thank you, Dr. Van Tilburg, and thank you to ANMS for inviting me to participate this evening. So it's a pleasure to be a part of this webinar series on brain-gut behavior therapies as treatments for GI disorders. And I'll be focusing on a topic that I'm very passionate about, which is how we can use gut-directed hypnotherapy to help patients with chronic GI disorders. And this evening, I'll be focusing on how we can apply this across the spectrum of disorders of gut-brain interaction. So just to do a brief review here, because we are talking about these brain-gut behavior therapies, and Dr. Keefer did such a nice job giving us a nice overview and updates on CBT. But just to remind everyone, we actually have 5 categories of brain-gut behavior therapies. So these are all psychological interventions that have been shown to have sufficient evidence at treating GI disorders. So we define these as short-term, non-pharmacological interventions focused on remediation of GI symptoms. So as Dr. Keefer was highlighting, our primary treatment targets with these interventions is on GI symptom management and improving quality of life for patients. And tonight we're focusing on GI-focused CBT and hypnosis because these are the 2 that have the largest evidence base and are really most commonly being used by gastropsych providers in clinical practice. And just as a reminder for everyone, really, the rationale for why do we use these psychological interventions to treat GI disorders, this is based on our conceptual framework of disorders of gut-brain interaction. And as all of you likely know, a key component of the biopsychosocial framework is that there's this interconnectedness between the brain and the gut, and these central processing mechanisms play a really key role in the onset and maintenance of symptoms for our patients. So you can see here that all 5 of these categories of brain-gut behavior therapies are able to use techniques that specifically target many of the cognitive affective factors that can contribute to brain-gut dysregulation. So we can target things like fear conditioning through interoceptive exposure, which Dr. Keefer was discussing. We can target the maladaptive cognitive processes. We can target chronic stress and psychological comorbidities. So I'll be focusing here on gut-directed hypnotherapy. So for those of you that aren't familiar with gut-directed hypnosis, I'll start with a brief refresher. So this is a legitimate medical tool. Don't worry, it's not like what you see in the movies or stage hypnosis shows. And it actually has a pretty long history of being used for medical purposes. So back in the 1800s, surgeons used to use hypnosis to help patients survive surgical procedures before we had modern anesthesia. And in more recent years, hypnosis is used in a lot of different medical settings. So it's been shown to reduce blistering and swelling for burn victims. It can reduce postoperative nausea and vomiting for breast cancer patients. And we know it can be very helpful for GI disorders, particularly for IBS. So it was first applied as a treatment for IBS back in the 1980s by Dr. Peter Warwell at the University of Manchester. So he conducted the first randomized controlled trial of hypnosis for IBS, which was published in the Lancet in 1984, showing it to be highly effective at reducing IBS symptoms. And this really paved the way for hypnosis research in GI and for it to be applied in clinical settings. So what exactly happens during hypnosis? So this is a clinician-delivered verbal intervention where we're encouraging the patient to enter into a special mental state, which we refer to as a trance-like state. And when they're in this state, we then deliver therapeutic verbal suggestions to facilitate certain psychological and physiological changes. So we can think of a hypnosis session as having kind of these two key components. So the first is the induction phase, where we're really trying to encourage the patient to enter into that more receptive mental state. So when they're in that trance-like state, the normal critical and analytical thinking falls away and the mind becomes more receptive to suggestion. And there are certain elements that we can include in the session that really encourage patients to enter into that state. So it involves a lot of deep physical relaxation through things like progressive muscle relaxation, diaphragmatic breathing. We encourage a narrow focus of attention. We utilize a lot of vivid, detailed imagery to engage the mind. And we encourage the gradual release of conscious control. So then once the patient's in this deeper state, we deliver what we call post-hypnotic suggestions. So these are metaphors, images, and specific verbal messages that are aimed at the patient experiencing certain changes in thoughts, emotions, and behaviors that we want to take place after the session has been terminated. And so that's really what the therapeutic ingredient is. That's what leads to the therapeutic change, is these specific suggestions. And because we're using this to treat GI disorders, these suggestions are focused on some of the mechanisms thought to underlie the disorders we're treating. So for example, the suggestions typically focus on things like reducing the frequency and intensity of pain or discomfort, normalizing gut motility, decreasing reactivity of the GI tract to stress, and increasing patients' overall confidence in managing their symptoms and also their overall sense of well-being. And the nice thing about hypnosis treatment is that it's really easy to customize it to address specific symptoms or conditions simply by adjusting the suggestions that we're using. So for example, if I'm working with a patient who has functional heartburn, maybe I'd have them imagine they're in a forest and they're breathing in the clean, fresh nature air, and that's creating a nice cool sensation that's spreading throughout their chest, alleviating any burning or discomfort. Or for a patient with functional dyspepsia, I may have them imagine they're soaking in a warm, hot spring, and the warmth from the water is soaking into their stomach, causing the stomach to relax, to become more stretchable, so that when they're eating and drinking, the stomach's more easily able to accept food. Or for a patient with functional dysphagia, maybe I'll have them imagine they're swallowing a soothing liquid, and this liquid is creating a nice slippery coating on their throat and esophagus, allowing them to swallow foods and liquids very easily and comfortably. And we have very good scientific support to scientific research to support the use of hypnosis specifically for GI disorders. Hypnosis is really unique in that it can both impact central processing of visceral signals, and then it also can impact physiological processes that are usually out of our voluntary control. So for example, we know in our patients with disorders of gut-brain interaction that there can be heightened levels of physiological arousal in their body from chronic stress and abnormalities in their autonomic nervous system. And this is something that hypnosis can specifically target. So through hypnosis and that deep relaxation we're encouraging, it increases parasympathetic activity in the body and helps to normalize the autonomic nervous system functioning. Hypnosis can also influence motility. So experimental studies have shown that When a patient's under a state of hypnosis, we can accelerate gastric emptying time for patients with functional dyspepsia. We can also slow down colonic motility, so it can directly influence the brain-gut axis in this way. And then it can also influence these psychological factors that we know are relevant for our patients. So the catastrophizing or the visceral anxiety that can predict more severe symptoms in conditions like IBS, those cognitive styles can be modulated by hypnotherapy. And then hypnosis can also influence that central pain amplification. So research has shown there's dysfunction in the limbic system of individuals with IBS that contributes to heightened levels of visceral pain. And research has shown that hypnosis can target these various brain regions that are involved in pain processing. And this has been demonstrated through neuroimaging studies. So this was a study published back in 2013, where the researchers used fMRI in patients who had undergone hypnosis treatment for IBS. And what they found is that the patients who had symptomatic improvement, so their IBS symptoms were reduced as a result of the hypnotherapy treatment, that their brain response on fMRI, their brain response to bowel stimulation, then resembled that of healthy individuals. So it seems that the hypnosis treatment had this normalizing effect on these brain networks that were involved in pain processing. So now that we understand the mechanisms a little bit, I'll touch on the efficacy of hypnosis. So much of the research conducted on GI hypnosis has been done in patients with IBS. And we have really strong support for the use of this as a treatment to directly reduce symptoms in our patients with this condition. So there have been at least 24 clinical trials. Nearly half of these are randomized controlled trials. And some of the largest case series that have been conducted in IBS patients with severe refractory symptoms, we see more than 70% of patients are symptom responders. Something interesting about hypnosis treatment is that also we tend to see non-colonic or non-GI symptoms often improve as well. So as you know, a lot of our patients with IBS have other comorbidities such as fibromyalgia or interstitial cystitis. And so what we see is that after they go through hypnosis treatment for their GI condition, things like backaches, headaches, fatigue, these other symptoms are also improving as well, which is a nice added benefit. And treatment also has great durability. So many of the clinical trials have followed patients up to 6 to 12 months after treatment and shown that patients maintain those treatment gains. One study even followed patients up to 5 years after they completed treatment, and the majority of patients had maintained the treatment effects. So where the field has really sort of lagged behind is in applying hypnosis to other GI disorders. So we know that other disorders of gut-brain interaction share some similar pathophysiology to IBS, yet there hasn't been a lot of research done on these other conditions. There is some strong support for the use of hypnosis for pediatric IBS and functional abdominal pain. We have one randomized controlled trial in functional dyspepsia, which I'll be discussing here in a moment. One in non-cardiac chest pain. And then we have some published case series and a pilot study in functional heartburn and globus, which are encouraging and showing some potential benefits for these esophageal conditions. So the one randomized controlled trial that was conducted in patients with functional dyspepsia was published back in 2002. This was done by the Warwell group, and they randomized 124 patients with functional dyspepsia to receive 12 sessions of hypnosis, or to receive an H2 blocker, or to receive supportive psychotherapy and a placebo pill. And what they found was that 73% of patients who underwent hypnosis treatment had significant reductions in their symptoms, compared to 43% receiving medical therapy and 34% in the placebo-controlled condition. So, really impressive findings, a well-designed, well-controlled study that they had done. But this was nearly 20 years ago. And sadly, not much research had been done since then on hypnosis for functional dyspepsia. So I'll quickly review for you a recent study that I completed. I collaborated with Dr. Ole Paulson at the University of North Carolina. He's done a lot of the GI hypnosis research, and we were interested in looking at hypnosis and functional dyspepsia, since it does share a lot of pathophysiology with IBS. And we were also interested in how we could test this as a self-administered treatment. So as Dr. Keefer had described, these digital therapeutics are gaining a lot of traction. And we actually designed this study pre-COVID, but during the pandemic, we're realizing, how important it is to find these other ways to deliver treatment. So Dr. Paulson and I co-wrote a 7-session hypnosis protocol for functional dyspepsia. So we, customized our suggestions to really focus on some of the mechanisms in dyspepsia. So gastric accommodation, visceral hypersensitivity, stress sensitivity in the gut. And then we recreated audio recordings of these 7 sessions, and we made them available to patients via a secure web portal. So they received seven sessions over the course of 12 weeks. So there was no clinician involvement in this treatment. So this was a study really to look at feasibility and acceptability. So it was not randomized. We enrolled 23 patients. We had excellent adherence. And so this is really encouraging in terms of these digital interventions. They're very convenient for patients. We only had 1 patient drop out over the course of the 12 weeks. And we saw improvements in all of our outcome variables from pre to post treatment. So reductions in dyspeptic symptoms, improvements in disease-specific quality of life, a decrease in visceral anxiety, and also improvements in psychological distress. And on a global measure of symptom improvement, 68% of patients reported their symptoms as being improved. And just quickly here, if we look a little closer at our primary outcome variables, so the patient assessment of upper gastrointestinal symptom severity index, the PAGI-SIM, assesses a whole range of upper GI symptoms. And what we saw was that patients not only had reductions in their dyspeptic symptoms, but they also had reductions in some of these other upper GI symptoms as well. So 5 of the 6 subscales showed significant improvements from pre to post treatment and at 3-month follow-up. So even symptoms like heartburn, regurgitation, nausea, vomiting, and bloating were also improved for our patients. So again, this is a pilot study, so these findings do need to be replicated in a randomized controlled trial. But I think it's very encouraging to see the potential benefit for patients with functional dyspepsia, and to have another example of how a self-administered treatment, has a lot of potential to improve access and just better disseminate these treatments to our GI patients. So to summarize, hypnosis is a well-established medical intervention, and we consider it an evidence-based treatment for IBS. It's able to target several of the key mechanisms that contribute to brain-gut dysregulation. And we want to start thinking about how we can apply hypnosis to the full spectrum of disorders of gut-brain interaction. And this is pretty simple to do by modifying our therapeutic suggestions. And I think it shows a lot of promise in particular for disorders of the upper GI tract. So thank you all for your time and attention this evening, and I look forward to taking your questions during the discussion.
Thank you, Dr. Kinsinger, for that talk that is near and dear to my heart, as we ran a trial in hypnosis in children with functional abdominal pain a long time ago, and I'm happy to see these become more accepted treatments. We will now go to our third and last speaker. Just as a reminder, put your questions for all the speakers in the Q&A. Some of them will be answered right as we're speaking. People are typing in answers, our panelists are typing in answers. But we'll also do some live after the talks. And then if there are any left over, they will be answered on Doc Matters. So our next speaker is Dr. Orock. Dr. Orock is originally from Cameroon in West Africa. He received his bachelor's degree in biomedical engineering at the University of Central Oklahoma and a PhD in neuroscience at the University of Oklahoma Health Sciences Center. Dr. Orock is a postdoctoral fellow in the Department of Neurogastroenterology under the mentorship of Dr. Beverly Greenwood van Meerveld. And his work focuses on revealing the mechanisms underlying stress-induced visceral pain seen in irritable bowel syndrome. Furthermore, Dr. Orock is investigating the mechanisms of how behavioral therapies and environmental enrichment may ameliorate stress-induced visceral pain. Dr. Orock was recently awarded the ANMS Discovery Grant to investigate whether behavioral therapies could also ameliorate post-infectious irritable bowel syndrome. Dr. Orock, I'm very excited to see what you will add to our talks today, because it will be very different focus and it's really exciting work.
Thank you very much for that introduction, Dr. Van Tilburg. And I want to thank the ANMS committee for inviting me to speak with you all today. And as mentioned, yeah, my talk is going to be somewhat of a different focus from the other talks before. So here I'm going to talk to you guys about how environmental enrichment inhibits visceral hypersensitivity by preventing stress-induced epigenetic changes in the amygdala. I know some of these words may not mean a lot to you right now, but hopefully by the end of this presentation, you will know what I'm talking about. So first, in order to find out the brain regions which were involved in the pathophysiology of IBS, IBS patients were put in an fMRI machine while they had a balloon catheter being distended in their colon. And so the doctors could look at the brain regions which were activated during the higher distensions. And as you can see here, they found that the amygdala was highly reactive in IBS patients. So the amygdala, this is the fear and emotional center of the brain. And our lab has been studying this, specifically the central nucleus of the amygdala, which I'll refer to as a CEA, for a while now. And we know it controls HPA reactivity. That's the hypothalamic pituitary adrenal axis reactivity, and also can influence pain. So normally during stress, the amygdala is activated and a corticotropin releasing hormone is produced, which goes on to facilitate the HPA axis, first by activating the paraventricular nucleus of the hypothalamus to release more CRH, the pituitary, which releases adrenocorticotropin releasing hormone into the circulation. This goes on to activate the adrenal cortex, which releases cortisol in humans or corticosterone in rodents. I'm just going to refer to it as CORT here. So one thing to note is CORT has a lot of different functions in the body to ameliorate the effects of stress. One of these is to travel back to the amygdala, where it activates glucocorticoid receptors, or GR. GR inhibits TRH in a negative feedback loop, thereby preventing continuous activation of the system. Now, however, in situations of chronic stress, this system actually reverses, and you now instead get facilitation of the stress system, leading to just further potentiation of the stress axis. So in order to show this, in our lab, we use CORT micropellets, which we implanted into the CEA of rodents. And then we measured the visceral hypersensitivity by counting the number of abdominal contractions to colorectal distension pressures. And as you can see, the animals which were, had the CORT implant in red have significantly higher number of abdominal contractions, signifying increased visceral hypersensitivity. Now, when we looked at the CEA and looked at the expression of these molecules, we saw that CORT significantly reduced the expression of GR while significantly increasing the expression of CRF, which is what we expect because of the facilitation of excessive stress. Now, finally, to show the importance of GR activity, we also had another cohort which we infused a GR antisense oligonucleotide to prevent GR activity. And doing this was sufficient to induce visceral hypersensitivity, as you can see here, again, counting by the number of abdominal contractions in these animals, similar to what you see in the group we just had the CORT implant. So moving on, the next question which we had was how is stress, an environmental signal, able to lead to such profound changes in gene expression? And this is where epigenetic modifications come in. Epigenetic modifications, also called like modifications on top of the genome, these integrate environmental signals, including stress, into the DNA. And these are long-lasting changes in gene expression. So there are three major groups of them. There are histone modifications, DNA methylation, and RNA interference. But for the purposes of this talk, I want us to focus mostly on histone modification, specifically histone acetylation of histones. So you have enzymes called histone acetyltransferases, or HATs, which will add acetyl groups to histones. This ends up unwinding the chromatin, allowing more access to the promoter regions, which leads to an increase in gene expression. On the other hand, you have histone deacetylases, or HDACs, which will remove these acetyl groups and contract the chromatin again, and essentially hindering access to the promoter regions, leading to reduced gene expression. So with this knowledge, we look back at our cord model, and we saw that animals which had the cord infusion also had significantly higher amounts of histone deacetylase bound at the GR promoter. And as expected, with the histone deacetylase at the GR promoter, we also see reduced acetylation at the GR promoter. This is implicating that epigenetic regulation could be the mechanism behind this molecular, the change in gene expression. And to highlight this point, we once again took our cord model, but this time we also infused an HDAC inhibitor. So this is to inhibit the activity of the histone deacetylases. And when we measure the visceral sensitivity of these animals, you can see that infusing the histone deacetylase significantly attenuated visceral hypersensitivity. So this is showing again that histone deacetylase activity plays an essential role in the pathophysiology of IBS. So that led to our research question, which is, can exposure to behavioral therapies before and during chronic stress, A, prevent the development of visceral hypersensitivity, and B, does it do this by preventing stress-induced epigenetic changes in GR and CRH expression in the CEA? So now to model animal behavioral therapies in rodents, it's going to be very difficult to try to model, hypnotherapy or cognitive behavioral therapy in rodents, since it's not easy to hypnotize them or ask them about their thoughts. But so we've taken a more generalized approach, which is to use an enriched environment as a rodent analog of behavioral therapies. So this entails exposing animals to an environment with sufficient physical and social stimulation of the brain. And multiple researchers have shown that putting animals in an enriched environment can decrease stress reactivity and also reverses inflammatory pain. So this is the model which we're going to use for behavioral therapy. Now, stress, we're going to use the chronic water avoidance stressor, or WAS. And this technique involves putting the animals in a container on an elevated platform surrounded by water for 1 hour a day for 7 days. We also had control animals, or sham animals, which were placed in a similar container, but no water, so they could come down and walk around freely. And at the end of each of these sessions, we collected fecal pellets and counted the number of fecal pellet output as a measure of autonomic stress response for the animals, to at least let us know the animals are feeling some measure of stress in this environment. So for enriched environment, we'll put 4 animals per cage. Again, these are larger cages, which have extra shelves, enriched food. They've got tunnels, toys, just all the things they could really want in there. And then control animals are placed in just a standard shoebox cages, 2 animals per cage, given regular rat chow and water. So we assess visceral or colonic sensitivity by the visceral motor response, which is counting the number of abdominal contractions to a 10-minute graded colonic balloon distension at pressures of 20, 40, and 60 millimeter mercury in freely moving rats. So again, these rats were anesthetized, put the balloon in there, and then we'll allow them to wake up before we continue the experiments. So we're also going to measure we're also going to assess the permeability of the colon. So for this, we measured the transepithelial electrical resistance, or TEER, of the colon. So this is a technique which measures the resistance across the membrane, and the resistance is the inverse of permeability. So this is going to give us a measure of how permeable this membrane is to small molecules. And as I mentioned earlier, epigenetics is very important. So we're also going to be measuring the changes in histone acetylation at the GR and CRH promoter regions. And as I mentioned, we also know that GR binds to CRH to inhibit its activity. So we're going to perform chip assays to measure exactly how much GR is binding to CRH in our various groups. So here's the first data point from this study. We put animals in an enriched environment for 7 days before and 7 days during the water avoidance stress. And as I mentioned, at the end of each day, we collected a fecal pellet output. And this graph here is showing, so the stress animals here in WAS, the blue and the red, you can see that housing the animals in an enriched environment did not prevent them from experiencing stress during this water avoidance stress. So EE does not prevent the acute effects of stress on fecal pellet output. Now, the next day, we took these animals and then we measured the visceral motor response. And as expected, seen here in red, the standard house WAS animals have significantly elevated number of abdominal contractions at distension pressures of 40 and 60 when you compare that to controls here in black, the sham. And also when you compare them to animals which are housed in an enriched environment in blue, as these animals have significantly lower number of abdominal contractions comparable to controls. So what we're seeing here is EE can prevent the induction of visceral hypersensitivity. So next, we also collected colon tissue from these animals, and we put it. We measured the transepithelial electrical resistance. Now, again, remember that this is giving us a measure of resistance, and so the higher the resistance, the lower the permeability. And when we look at the standard house WAS animals here in red, you can see that they have a significantly lower tier compared to sham controls, and also compared to stress animals, which are housed in an enriched environment, who are showing comparable tier to sham controls. So what we're seeing here is EE also prevented the increase in colonic permeability. So for our next data set, that's when we're going to start looking at the epigenetic changes. So for this first graph, we measured the H3K9 acetylation at the GR promoter. And as expected, stress significantly decreased acetylation at the GR promoter, as you can see here in red. However, pre-exposing the animals to an enriched environment prevented this effect. Next, when we looked at the CRH promoter, we see the inverse. So we see that stress significantly increased acetylation at the CRH promoter, seen here in red. However, pre-exposing these animals to an enriched environment prevented this increase in H3K9 acetylation at the GR promoter. And finally, when we looked at GR binding at the CRH promoter, again, based on these first two graphs, we expect to see less GR expressed and more CRH expressed. And we can see here that when we're looking at GR bound to the CRH promoter, we see less GR bound to the CRH promoter in the stressed animals who stayed in the standard housing. However, housing these animals in an enriched environment before and during the water avoidance stress was able to prevent this decrease in GR binding at the CRH promoter, maintaining GR binding at the CRH promoter to naive levels. So in summary, what I've shown here is that pre-exposure to an enriched environment before and during chronic stress prevents stress-induced visceral hypersensitivity, and it does this by suppressing stress-induced epigenetic changes at the GR and CRH promoter regions in the CEA of rodents. And I've also shown that EE can inhibit stress-induced increase in colonic permeability. So in conclusion, what this data is showing is that behavioral therapies can inhibit epigenetic and molecular changes induced by stress to prevent visceral hypersensitivity. And I published this work in 2 papers which were published in the last year. And there's a lot more information in the papers which I could not cover in the talk today due to time constraints. So before I leave, I would like to acknowledge my 2 mentors, Dr. Beverly Greenwood Van Meerveld and Dr. Anthony Johnson, for all their help in this project. I would also like to thank the current members of our lab, Ehsan Mohammadi and Casey Ligon, as well as the previous members of our lab for all their help on this project. And last but not least, I would like to thank the funding agencies. I would like to thank the VA, as well as the University of Oklahoma for funding this project. And I will also like to thank the ANMS committee for granting me the Discovery Grants Award to continue on this research. And I will end there, and I'll be happy to take any questions. Thank you very much.
Thank you for a really insightful talk, Dr. Orock. We're finally getting to what it really is that we're doing on almost a cellular level, right? At least on our brain level when we're doing cognitive behavioral therapy. So there's a lively discussion going on in our Q&A, and I would just remind everyone, put your questions in there. Although most questions of the 2 previous talks have already been answered, I think there's more of a general question that I want to distill and ask Dr. Kinsinger and Keefer to maybe respond to that. You know, one of the questions was like, how really, how do you refer to cognitive behavioral therapy or hypnosis? And perhaps also related to that, who do you refer? Because, Dr. Keefer, you talked about this is not just treatment for anxiety, right? So sort of a couple of questions together. Could the two of you maybe address that?
I mean, I can start, and then Sarah can. I think we probably have somewhat different. We both look in different sort of settings, but so first of all, I think that the thing I encourage the physicians to do is really master their elevator pitch on how to explain the reason for a referral, right? And we've Sarah and I have spent a lot of time really trying to cultivate the terminology of brain gut behavior therapy, referral to a clinical health psychologist, a GI psychologist. All of these things kind of improve the uptake, reduce the stigma. The other thing that I think is also helpful is I often talk to patients about how, their GI issue, their DGBI is a software problem. And while it's sort of the equivalent of having, these GI symptoms coming up to the brain and the brain paying too much attention to them. And I say it's like it's a software problem on your phone, right? It's an app that's running in the background, tracking your location all of the time, right? And our job in behavior therapy is to get that app to stop tracking your location and spending time and energy on amplifying symptoms that are really just false signals most of the time, right? So I think those are helpful for physicians to really master their metaphors, master their explanations, and then also make sure that the patient knows that you're just adding to the team. You're not actually sending them away because you think it's all in their head. So that would be sort of my, strategy, and maybe Sarah can speak about who's appropriate and how you know.
Yeah, that's very nice description there, and I agree. I think for the physicians to be able to talk about this brain-gut connection as the rationale for why we're using this approach is important. And I also encourage physicians to think about just really validating for the patients that these are complex conditions, because I think sometimes patients have heard the message like, well, you just need to manage your stress better, or, that it can be communicated in sort of a dismissive way. So I think it is important, for the team to validate that these are complex conditions, and maybe stress is just one of the factors, or these brain gut pathways are one of the factors that are, contributing to more severe symptoms. So, let's find some tools to help address that piece of the puzzle. In terms of who's appropriate, so, certainly patients who are having significant impairments in their quality of life because of these conditions, patients who are endorsing the GI specific anxiety symptoms that we often see, the catastrophic thinking, the preoccupation with their symptoms, or they're engaging in some maladaptive kind of behaviors because of their condition. Those are things to look for that may be kind of a red flag that they may benefit from seeing a gastropsych provider. We do discourage referrals for patients who have more severe psychopathology. So if the patient has more severe depression, or a condition like OCD or active post-traumatic stress disorder, we want to refer them for mental health care to address those issues first and foremost. And when those issues are more stable, then they may be appropriate for a more GI-focused treatment approach. We do see, there are high rates of trauma in our patients. So we do see quite a few patients with a history of PTSD. As long as it's been addressed and it's stable, they may still be appropriate for a treatment like hypnotherapy. And if you're not sure, this is where a consultation with a GI psychologist is really helpful, because we can meet with the patient, we can assess for these things, and we can let you know if they're a good candidate.
I am muted. Sorry about that. These are really wonderful suggestions. I'd like to quickly sort of on the end of our time together, ask Dr. Orock. You gave some really interesting data on rats and how if you enrich their environment, we see all these changes in visceral hypersensitivity. And now we can study, do studies that we can't do in humans to really see what's going on and how we can change these things. I wanted to ask you, because an enriched environment makes me think about play, right? And children learn through play. We have a lot of children who have these type of disorders. How does play enter into this? And maybe we all should be playing more as adults too, but have you thought about that?
I have actually. Every time I've given this talk, someone always asks me, so if I just get all the best things and put in my house and live with my family, is that good enough? Which I think there is an aspect of that. But one thing here, which I didn't get the chance to really expand on, is I kept changing the toys. I kept changing the environment in there. So it had to be novel. There had to be an element of novelty in it. Now, as far as transferring that to humans, I think play actually does work, because it comes down to, as the other two panelists mentioned, humans can think too much about your symptoms. They catastrophize the pain. But if you're distracted, you're having fun with family, you're doing something else, you have you're not spending all that time catastrophizing on the symptoms. So that's where the direct correlation sort of goes. I think of it sort of like when my rats come out of the stress, they get those in the standard house cages are in there just like, I've got nothing else to do here. All I can do is think about that platform, and I'll be back there tomorrow doing the same thing again. And when will this ever end? While the other ones get back in their kitchen and looks like, wow, that was stressful. All right, gonna get me some Fruit Loops, gonna get me some toys. Guys, come on, let's talk about this. All right, thank God we can do this. Otherwise, I'd be stressed out of my mind. So that's sort of the direct analogy that I'm looking at. But it can't just be, here are toys, go play. Eventually it can get boring and it has to be something that is engaging. So it doesn't have to be 24 hours engaging, but a few hours, get something, get some engagement in it. I think that's the way, that's the more direct translation. Did that answer your question?
Brilliantly, yes. Thank you. So we're coming towards the end of the time for us together. I know there's a couple of just open questions out there still, and the panelists will be answering those on Doc Matter. If you have any other questions, you can go there as ANMS members and interact with each other. I really would like to thank all of our panelists today for excellent talks and giving us all of this information. And I hope it was helpful for everybody who was on here today.